Thank you. I believe coffee is not over yet, but we have to start, otherwise that telephone will ring. I would like to say we are privileged, all of us as colleagues, that we are going through the success, what we have seen. We are all part of it, and we should be proud of it. I have tried to put up where we stand now. I'm not going much in the future, so you will see how we have changed and are changing the standard of care of our patients. These are my declaration of interest. So endometrial cancer remains the only gynecological malignancy with rising incidence and mortality. While patients diagnosed in early stage, low grade, they have excellent prognosis with surgery alone. The patients in the late stage, they have really bad prognosis. 5-year survival is only 17%. So carboplatin paclitaxel has a great response. However, if you look at the 3-year overall survival after carboplatin paclitaxel, it's less than 50%. So this is a real unmet need. And we can see now that anti-PD-1 immune checkpoint inhibitors have transformed the management of endometrial cancer in the post-platinum chemotherapy, and now a month ago, the data was presented. It's going to dramatically change also in the first line. I have put some, when I was making my talk, I put the timelines, what we have achieved in the first line treatment, stage 3, 4, and first relapse disease. You can see that 1961, we introduced progestin. And since then, nothing new came in until about 15 years ago when we introduced carboplatin and paclitaxel. And after that, again, nothing. This is where we stand with first-line treatment of endometrial cancer, and which is quite pathetic. And 2021 started the big change when we saw the immune therapy results of the monotherapy and the combination therapy in the metastatic disease. And then in 23, we have seen the first-line treatment results in the 2 phase 3 trials. So if we look back to the carboplatin and paclitaxel, you can see, as I said, that this is the best trial we have, GOG-209, and you can see that at 3 years overall survival, less than 50% of the patients are alive. This is what we have. And we think that's like ovarian cancer. No, it's much worse than ovarian cancer. And what if these patients have relapsed on carboplatin and paclitaxel? We treat them with single-agent chemotherapy. Responses are about 10%. Median PFS in average is about 3.5 to 4 months. Again, very pathetic results. And this is where we stand today. And you can treat with hormonal endocrine therapy or chemotherapy single agents, the same results we have. I think the biggest change what has happened in endometrial cancer was the introduction of molecular classification, the TCGA classification, almost a decade ago, where we started understanding that it's not just type 1 and type 2 tumors, but it is actually quite a heterogeneous disease, and there are quite a few targeted therapies possible for these tumors. And the first thing we introduced was immunotherapy, because as you can see, the preclinical data, this is a tumor where you will really see a subset of patients, quite a big subset of almost 1/3 of the patients who have very high responses to immune checkpoint inhibitors. And that was the reason that we started with single agent immune checkpoint inhibitors. We did trials in all patients, and then we divided into look at the mismatch repair deficient and proficient disease. And when we looked at and these the trials were done in the second plus line, and when we saw that, we saw in all trials there was tremendous benefit of single agent immune checkpoint inhibitors when it comes to the so-called hot tumors, MMR deficient disease. These are about 30% of the patients, not 70%. So we saw, now we have possibility in Europe to treat patients with either pembrolizumab single agent or dostarlimab single agent in the population which is biomarker positive. That means mismatch repair deficient or MSI high. And the results came, the first results were from pembrolizumab trial, this Keynote 158, which showed that response rates were about 50%. I just told you that in chemotherapy alone, the response rates are about 10%. And this is a huge, huge increase. The largest this is a non-randomized trial, and EMA is normally very conservative to approve anything on non-randomized trials. And you can see that the patients who had responded, they had a long duration of response. So this is the reason why pembrolizumab got approval on a non-randomized trial by European Medicines Agency to be treated in patients who are DMMR in our post-platinum era. The largest, again, non-randomized trial which is performed is with dostarlimab, the Garnet trial, and about 150 patients in those were those who were DMMR, and it showed again a response rate of 45%. Which is really amazing. And again, you see that the patients who respond, they do not have a short response time. They have, you can see that the curves are flattened for probability of progression-free survival in the patients who are responding, and we still have patients who have not progressed who were on dostarlimab. So these two drugs got approved on non-randomized trials because the difference from what unmet need was to today is so huge that EMA, such a conservative society, agreed to approve the drugs. Then we have to think about the 70% of the population, which is, I would call, cold tumors when it comes to immune checkpoint inhibitors, because they are MMR proficient. And that means that when we look at the single agent activity of immune checkpoint inhibitors, is about 10%, the same as monochemotherapies. That's not very interesting. So we started to work to combine treatments with other drugs. One of the major drug first move was to combine with an antigenic small molecules because it reduced the Treg activation and it reversed the immune suppressive effect of VEGF. So that was the first, but you will also see later that we have tried to enhance the efficacy of immune checkpoint inhibitors by giving them together with chemotherapy, and we will also see the data later this year of combining them with not only chemotherapy, but also with PARP inhibitors. So all this is happening. Things are changing. This talk will be old in a couple of months when the new data come in, because things are moving so fast that standard of care is changing. It's very difficult because our national guidelines have to change all the time. So this is so that's why we combined the two drugs. Vicky Magar presented the data on Keynote 146. That was again a non-randomized trial, about 100 patients, and these are all tumors, the MMR deficient and MMR proficient. The blues are proficient, the reds are deficient, and this waterfall plot tells you something very important. One thing is you look at the response rates, which is about 38%, but look at the tumor size. Almost all tumors are shrinking. There are very few patients where tumors are not responding. So that is very encouraging, and that was the basis for the first phase 3 trial of immune checkpoint inhibitors in endometrial cancer. That was the Keynote 775, where patients who had advanced metastatic or recurrent endometrial cancer, they had measurable disease by blinded independent radiology review, and they were stratified according to MMR status, because we know that they will respond very much to the MMR deficient disease. So they were randomized. The idea was to make the cold tumors hot. that the patients who are MMR, who have tumors which are MMR proficient, they should respond. So the primary endpoint actually was to look at the MMR proficient disease and then all the other endpoints. And the very, very interesting statistical analysis, the way it was done was first you looked at the PFS in the MMR proficient. If that was positive, alpha was passed to the intention to treat population. Once that was positive, alpha was then passed to the MMR proficient overall survival, and then to intention to treat overall survival, and the end the same for the response rate. So there are 6 primary endpoints in this trial. Amazing statistical design. And when you have this hierarchical design, you don't need 5,000 patients. You can use alpha from one to another, and with a smaller number of patients, you can get these results. So this is, and the comparator was the best treatment for these patients. This is post-platinum treatment where you give single-agent doxorubicin or single-agent weekly paclitaxel, so that was allowed, one could choose. So this is against single-agent versus doublet with endpoints. And we look at the primary endpoints of progression-free survival. First, as I said, it was in the MMR proficient disease, and then in the overall population. You will see these curves are not what we were used to from, say, bevacizumab or chemotherapy, the banana curves, where they fall into each other. They keep the separation all the way along, and they're not falling into each other. That is very important. So this is long-term benefit, both in MMRP with a hazard ratio of 0.60, if I remember, yes, and in the overall survival as well, and the PFS for the intention to treat population as well. Another very important thing you can see here is the standard of care arm. As I said, no matter what chemotherapy you are using, median PFS is about 3.5 to 4 months. That's what we had. Okay, when we look at the other primary endpoints, overall survival, again, these curves start separating and keep their separation all the way along. So this is the first phase 3 trial, what was done in the post-platinum disease, which showed clear benefit in all parameters which you could see. And of course, the next question was, why we have to wait for relapse? Why don't we go up front? And I think there was a race of pharma companies of trials which started there, and they started asking different questions. Anti-angiogenic, that's one, and Christian is somewhere here in the room. I'm looking forward to his talk once it comes out. Then the other question was asked if there's a biological rationale for combining immune checkpoint inhibitors with chemotherapy for the immunogenic cell death and enhanced presentation of tumor-specific antigens. So why don't we combine it with carboplatin paclitaxel and see if we can increase the efficacy of immune checkpoint inhibitors, both in the proficient and deficient disease? Another question was asked on top of that, if we can add PARP inhibitors, especially in the serous population, P53 mute, probably we will get even higher response. So these are the 3 major questions being asked in a long list of first-line trials which are here. When you look at the all red ones are asking one question: can we get a better outcome by introducing immune checkpoint inhibitors on top of carboplatin and paclitaxel? So these are carboplatin paclitaxel plus minus immune checkpoint inhibitor. You can see the EN6, a 10 trial, NRG018, EN11. All these are asking the same question. First 3 trials have an almost similar population, and EN11 has a more early adjuvant population. The blue ones are asking on top of that you're giving chemotherapy plus immune checkpoint inhibitor, if you add PARP inhibitor, because there is a biological rationale for combining PARP inhibitors with immune checkpoint inhibitors, you will enhance response. We will see very interesting data coming on ovarian cancer in ASCO, the DUO-O trial, which will be the first one to show this positive benefit. And this is the question we are asking, and probably we will see one of the two trials results by end of the year. I think the most exciting until now has been, what if we can get rid of carboplatin paclitaxel in first line? So these three trials, the green ones, are comparing carboplatin paclitaxel against non-chemotherapy combination. The LEAP one is, I would say, the same as 775, Keynote 775, but in first line. And we hope to get results by end of this year for that. Looking forward to it. And the last two trials are asking the question only in the hot tumors, MMR deficient disease, those 30% of the patients, if we can give immune checkpoint inhibitors alone, would it be better than chemotherapy alone? And I believe they are after seeing the data. So until now, we have result of the two, which were presented a month ago, 27th of March, almost. Yeah, it is 27 today, a month ago. Ruby trial was presented both at ESMO Virtual Plenary and at SGO on the same day, and Energy trial was presented at SGO the same day. So these trials were presented at the same time, and they were published in New England Journal the same day. So let's look at these trials, which are going to change our standard of care. Ruby trial, the ENGOT EN6 trial, was a trial for stage 3, stage 4, and first relapse patients. If patients had rare diseases like carcinosarcoma, they were entered. That's very important. That was part of the study. So we did not let them go. We put them in carcinosarcomas in this study. And another thing was, we had a lot of discussion, the patients who have received adjuvant chemotherapy to start with, how much time we should give that we will put them in the trial. The question is it 6 months platinum-free interval or 12 months? We decided to do 6 months. So this is a platinum-free interval of 6 months. And then these patients were stratified according to MMR status, according to the stage of the disease, 3, 4, or first relapse, and according to if patients have received radiation therapy before or not. These patients were randomized 1-to-1 to receive carboplatin paclitaxel 6 cycles together with either dostarlimab or placebo, and then continued on monotherapy of dostarlimab or placebo up to 3 years. So this is the trial design. Primary endpoints, again, were the same way as you saw the 775 were multiple, and I'll come back to that. So that gives us possibility to see on both PFS and OS in this trial. I think another very important thing when you will look the two trials together is the follow-up time. The follow-up time in this trial is 25 months at the time of data cutoff, while in the other trial you will see it's 7.9 months. So that trial has to get more maturity in future. So when we look at the results by one primary endpoint to other, you look at the progression-free survival in the MMR deficient disease. At 24 months, you see that progression-free survival has increased from 15 months to 61 months, right? And another very important thing is the shape of the curve. You can see that the curve falls down till 12 months, and then it's completely flat. There are no events in the dostarlimab arm. So my next question would be, I will ask scientifically why we have to go for 3 years of dostarlimab. Probably we can shorten that. We did the same procedure in melanoma, started with longer and shorten, and other diseases. I think this is what we are going to do. But the best thing is probably some of these patients are cured because you don't have any progressions happening since then, and hazard ratio is 0.28. When we look at, for the same subgroup of patients, the overall survival, although there is only 33% maturity, you see again the same hazard ratio of 0.3 for overall survival, and you see the curves are flattening for the dostarlimab, which is telling us definitely, I believe that we have cured quite a few patients here as well. So I think, and this is despite the fact that 38% of the patients in the placebo arm, after they progressed, they received one or other immune checkpoint inhibitor, 15% in the other group. So you got that crossover, but still you see overall survival benefit. That also tells us indirectly, push the immune checkpoint inhibitors up front. That's the best place for these drugs. When we look at the overall, that was the second primary endpoint, overall survival, PFS in overall survival. Again, you see doubling at 24 months from 18% to 36% with a hazard ratio of 0.64. And when you look at the overall survival of the same population, again, we still have only 33% maturity, and there is considerable crossover from placebo to about 34% of the patients received immune checkpoint inhibitors after progression. The hazard ratio is 0.64. Again, extremely positive outcome for the whole population. The third group is the MMRP, the proficient disease. Again, you see the increase in PFS from 18% to 28% at 24 months with a hazard ratio of 0.76. Here it's very important to look at the overall survival also, because if you see a benefit in overall survival, this is a real benefit. And we are still at 33% of maturity. The hazard ratio is about 0.73. The boundaries are just crossing 1, but we hope we will be repeating this analysis later this year to see if we have enough events, and we will have a closer confidence intervals. So on these bases, GSK 2 days after presentation submitted the DMMR population data to European Medicine Agency. They said they would wait for MMRP correctly when we have the overall survival data. So I hope we will get approval hopefully this year. I don't know how fast EMA is going to work, but EMA has accepted the application. There was a press release 2 days ago that, I think this will change our standard of care. Let's go to the other trial, NRG-018. There are some differences here. First of all, carcinosarcomas are not part of it. And second is that the duration, platinum-free interval for the patients who received adjuvant chemotherapy is 12 months. And the stratification factor is different because you have prior adjuvant chemotherapy, not prior radiation therapy. So there's some differences. I think the major difference is that the follow-up time is only 7.9 months. So we have to wait for a longer period to get more data. But then another difference is that the duration of pembrolizumab is up to 2 years. I don't think that will have any influence when we saw the Kaplan-Meier curves in that. So, and another statistical design difference is that here you don't have overall survival as primary endpoint as it is in Ruby trial. However, here you have both MMR deficient and proficient as primary endpoints. And they have done the statistics in the old way, so not a hierarchical design. So they have 800 patients divided into the 2 groups. And when we look at the DMMR population, again, you see PFS of 0.3. And if you look at the MMRP population, a PFS of 0.54, we should be a little bit cautious because we have to have longer follow-up. But I believe that these 2 trials are supplementing each other, supporting each other, and both drugs will be approved for treatment of locally advanced and recurrent ovarian cancer while we are waiting for other drugs. So my takeaway message would be immune therapy plus carboplatin paclitaxel represents a new standard of care for patients with primary advanced and recurrent endometrial cancer. There is a substantial unprecedented benefit in the MMR population, and there's clinically meaningful long-term benefit in the MMRP population. So when we presented these trials, you may all remember our dear colleague from US, Deborah Armstrong. She wrote to me. So she wrote, these are very moving results. We take mostly baby steps, but Ruby and GY018 are giant leaps. If you remember, giant leaps come from Neil Armstrong when he jumped on the moon and walked. So we are at the beginning. You saw just the results of 2 trials. You saw the tsunami of trials coming in, and you haven't seen yet the other targeted agents we are working on. So I think we are really helping our patients a lot. Thank you.